In today's video at Medical Sciences by Naftali Muhumuza, we want to discuss about Parkinsonism, or you can call it Parkinson's disease, which is a neurodegenerative disorder commonly affecting the elderly, those ones who are 60 and above years. So we want to look at the cause, what causes Parkinson's disease, then what are the signs and symptoms of the disease, and which type of drugs we can use to treat this disease. And as we begin, we always remind you to subscribe. Then you hit the like button, and in the comment section below, you can share your comments so that we can continue to grow. So before we begin the disease, how it comes about, we have to look at the part of the brain that controls or that prevents Parkinsonism from occurring. And we're going to see that in the cerebral hemisphere of the brain, we have what we call basal ganglia. And this basal ganglia is divided into two nuclei. That is the caudate, which is tail-like, then the lentiform. And the lentiform is further divided into globus pallidus and putamen. And these three, the caudate, which is tail-like, which looks like a tail, then plus the globus pallidus and the putamen, these three of them forms what we call stratium, forms what we call stratium, we call it corpus stratium. So this is the three components of the corpus stratium: the globus pallidus, the putamen, and the caudate, which are part of the basal ganglia. And we are going to see that the corpus, why do we call it corpus stratium? It is striated. It is a part of the brain, the basal ganglia, which is striated. That's why we call it stratium. And this corpus stratium, which has three nuclei, it is always controlled by the part of the brain known as, this part of the brain is known as substantia nigra. So we are going to see that this part of the brain, which is below the thalamus, is the one that sends neurotransmitter that controls the corpus stratium. So this substantia nigra is the one that releases neurotransmitter such as dopamine. Releases dopamine together with acetylcholine, and these two neurotransmitters produced by the substantia nigra, which is below the thalamus, they are the ones that controls this corpus stratium. And this dopamine and acetylcholine, they do what we call opposite reactions, whereby dopamine, for it to be affected or to be under balance the brain, dopamine should be, they should be of the same, they should balance, dopamine and acetylcholine. So Parkinsonism comes in whereby there is low levels, is due to whereby this substantia nigra degenerates or fails to function. Hence, there is no more production, there is decrease in the production of dopamine. Whereas acetylcholine, which is produced from the thalamus, is going to increase. So when there is this failure to balance dopamine and acetylcholine, is the one that results into Parkinson's disease, whereby Parkinson's disease is due to failure of substantia nigra, which will fail to release enough dopamine. And when dopamine is little in the brain stem, it is going to be low compared to acetyl. So acetylcholine will remain going high, whereas dopamine is low. So that failure to balance the dopamine and acetylcholine is the one that is going to result into what we call Parkinson's disease, whereby the acetylcholine when it increases in the concentration or when it accumulates, it is going to fire the muscarinic receptors, bringing about body movements, contractions, whereas the dopamine which counterbalances it is low. So there is continuous stimulation. So that is what we can talk about how Parkinson's comes about. Note this, that Parkinson's is due to the degeneration or failure of substantia nigra to release dopamine. And because it is failing to release enough dopamine, we are going to see levels of dopamine in the brain which controls the corpus striatum goes low, whereas acetylcholine goes high. And it is this one will result into failure to control the corpus striatum, which serves different peripheral tissues of the body, like the eye, like the skeletal muscles, and the GIT. So the end result of this imbalance, that is low levels of dopamine, we are going to see that low levels or decrease in dopamine together with increase in acetylcholine is going to result into signs and symptoms like tremors. It's going to cause tremors. It is going to result into stiffness of the muscles. There is stiffness of the muscles. Then another thing, this stiffness of the muscles can even result into mask-shaped mouth. Then other things we shall see is that majorly tremors, stiffness is one of the peculiar signs of this Parkinson's disease. Then others we can see is muscle rigidity, which we are calling stiffness. Then we can also see dyskinesia happening. Dyskinesia will happen together with hypokinesia. Whereby dyskinesia is uncontrolled movement, whereas hypokinesia is reduced muscle movements. So these are the peculiar signs of Parkinson's disease, whereby there is uncontrolled muscular movements, whereby someone's with Parkinson's disease, you find their hand is in continuous shaking uncontrollably. That is what we call Parkinson's. Then stiffness, or what we call muscle rigidity and tremors, they are the one that causes this continuous and controlled muscle movements. Then dyskinesia is whereby, because they are uncontrolled and they are very faster, then hypokinesia is whereby there is slowness in the movement. So these are the major signs and symptoms of Parkinson's. So these are signs and symptoms due to decrease in dopamine levels and increase in acetylcholine, whereby there is a failure of substantia nigra to release dopamine, hence failing to control corpus striatum, which supplies the peripheral tissues, majorly the muscles. So after seeing at this physiology, and when there is failure, that this one results into this Parkinson's disease, now we are going to look at, before we begin the treatment, we are going to look at how is the dopamine released in this. So if this is the substantia nigra, the neurons within the substantia nigra, there is always tyrosine amino acid, and this tyrosine amino acid is moved into the neuron. It enters into the neuron, whereby it is a precursor for formation of dopamine. In the presence of tyrosine hydroxylase, it is converted to dopa. And this dopa, in the presence of decarboxylase, it is converted to dopamine, which is our neurotransmitter. This one is in the presence of tyrosine hydroxylase. Then this is in presence of dopa decarboxylase. Decarboxylase enzyme. which removes the carbon dioxide group, forming dopamine. And this dopamine neurotransmitter is the one that is transported into the synaptic vesicle. So we see this dopamine formed is stored within the synaptic vesicle, so that in case we need more to be released, upon entry of calcium, when calcium enters, which causes the power stroke, leading to the fusion of the synaptic vesicle with the membrane, leading to the release of neurotransmitter by exocytosis. So dopamine is released. And when it is released, it comes and attaches to its receptors on the postsynaptic neuron. And this postsynaptic neuron is the one that is found on the corpus striatum. Then this one we said it is a part of the substantia nigra. This is the neuron supplying it. So when it is released, some of it goes and attaches on the dopamine receptors, that is the D1 and D2 receptors, whereby in the CNS we find there D1 receptors, then in the periphery we have D2 receptors, that is dopamine 2 receptors. So when it binds on this postsynaptic membrane, it is the one that causes firing of the action potential. Then the remaining dopamine in the synaptic cleft, some of it, there is what we call one pathway to metabolize it is reuptake. Some dopamine is taken back into the presynaptic neuron, and when it is taken inside, it can be metabolized by MAO. So that this MAO, that is monoamine oxidase, it breaks it down into metabolite, which is later excreted. Then another excess of the dopamine in the cleft, this is a minor pathway whereby it is methylated by COMT. COMT is a catechol or methyl transferase. Catechol or methyl transferase is going also to metabolize or to add a methyl group, forming O3 methyl dopa. 3 or methyl dopa, which is an intermediate after adding a methyl group on dopamine by COMT. So after looking at this, we are going to see different drugs which we can use to treat people with the Parkinson's disease, whereby we are going to see the precursors, whereby precursors we shall have, we're going to see them, whereby we shall give levodopa and carbidopa. This levodopa is the intermediate, or it is the one, it is a precursor for dopamine formation, whereby this levodopa or aerodopa is taken inside because for it has ability to cross the CNS, so it is able to be used as a precursor. Whereas carbidopa, we are going to see, for it targets decarboxylase, it inhibits dopa decarboxylase. So without wasting any time, we are going to see different drugs that inhibit. We are going to see COMT inhibitors, we are going to see MAO inhibitors in treatment, and we are going to see those ones that increase dopamine levels in the synaptic cleft. As we have seen, the problem is decrease in the dopamine. Then also we have seen the problem also is due to increase in acetylcholine. So we shall also see drugs which can reduce, which can decrease acetylcholine. So without wasting any time, let us begin on the drugs which we use to treat people with Parkinson's disease. And one of them is dopamine precursors, which we have outlined here, that is levodopa, or you can call it aerodopa. Levodopa, then we shall see carbidopa. These are the dopamine precursors, whereby we have seen levodopa. For it, it has the ability to cross the blood-brain barrier. So when taken, we're going to see levodopa crossing the blood-brain barrier, entering into the substantia nigra, and when L-dopa enters, it bypasses the process of tyrosine because it already contains tyrosine, whereby it is converted to dopa. Then in the presence of decarboxylase, it is converted to dopamine, then taken into the synaptic cleft. And here the major concept is to increase, because under treatment there are two major goals we need to achieve, either to increase dopamine or to reduce acetylcholine. So here we are increasing dopamine. So when levodopa crosses the CNS or the blood-brain barrier, it leads to the formation of dopamine, and when more dopamine is formed, the more will be released, and it will increase in the synaptic cleft, hence increasing the chances of binding. But we are going to see this levodopa, which crosses the blood-brain barrier and is used as a precursor for formation of dopamine, is not effective when used alone. Why? Because in the peripheral tissues, we also find an enzyme which is called dopa decarboxylase. And this dopa decarboxylase it is in the presence of dopa decarboxylase enzyme, it breaks down this levodopa into intermediate. So when this levodopa is broken down, it decreases the chances of this drug reaching the CNS to increase dopamine levels. But we are seeing there is another precious drug called carbidopa. And this carbidopa, for its mechanism of action, it acts by inhibiting. It inhibits dopa decarboxylase. So when we give levodopa in combination with the carbidopa, we increase the bioavailability to the site, or we increase the levodopa reaching the site, reaching the CNS to increase dopamine levels. So it is always required to use the levodopa in combination with the carbidopa to increase levodopa to enter into the CNS or to cross the blood barrier by inhibiting peripheral tissue dopa decarboxylase. And this dopa decarboxylase acts in the presence of vitamin B6, and we shall see some drugs which are not good to be taken with vitamin B6. So it is not good to give levodopa and carbidopa in combination with vitamin B6, what we call pyridoxine, because it will enhance the action of decarboxylase, hence rendering carbidopa non-functional. So it should not be taken, because when taken together with these drugs, it will decrease the action of carbidopa and increases action of decarboxylase. So it should never be taken in combination. And one of the side effects of levodopa, it causes peripheral effects. We have like vomiting, nausea is one of the effects it leads to. Then other effects of this drug, it can lead to what we call, it can affect it can cause what we call orthostatic hypotension or postural hypotension. It can result into cardiac arrhythmias, and it can also result into dyskinesis, or what we call dyskinesia. So these are some of the adverse drug reactions when taking levodopa in combination with carbidopa. Then another drug we can discuss in this session is inhibitors of dopamine metabolism, and one of them we are going to see more in type B inhibitors. Here, these drugs we are going to use, they are selective for type B, monoamine oxidase, which also metabolizes dopamine after being reuptaken. So an example of these drugs we're going to have Sereglin is one of the drug, and Rasagirin. So these are the two drugs which are selective for MAO type B inhibitors, what we are calling monoamine oxidase inhibitors type B. But among this one, the most potent is Rasagirin and long-acting compared to Sereglin. And these ones, when taken, for them, their mechanism of action is that they inhibit monoamine oxidase enzyme. And this monoamine oxidase enzyme is the one responsible for metabolizing this dopamine. So when taken, these guys, they are going to inhibit monoamine oxidase, hence we shall not metabolize this dopamine. So there is increased chances of this dopamine to be taken back to the cleft, then also exocytosed into the cleft, so increasing the levels of dopamine within the cleft. So that is the mechanism of action of Sereglin and Rasagirin. And these ones, they are also best, or they give better the results when taken together with levodopa and carbidopa. And the side effects are the same for these two drugs, but we have said the most effective is Rasagirin. Rasagirin is more effective than Sereglin. Then other drugs we have COMT or catechol or methyl transferase inhibitors, which are responsible for also metabolism of dopamine. That if we have dopamine, it is metabolized by COMT by adding a methyl group to form 3-O-methyl-dopa. So when we give these drugs like tolcapone and entacapone, these two drugs inhibit catechol or methyl transferase, hence inhibiting the degradation of dopamine from the synaptic cleft into 3-O-methyl-dopa. This is in CNS, and we are going to tell you that among these two drugs, tolcapone is most effective because it has ability to cross the blood-brain barrier. So it acts both in the CNS and in the peripheral tissue, whereas entacapone works only in the peripheral tissue because it cannot cross the blood-brain barrier. So we are going to see tolcapone being the most effective in combination with levodopa and carbidopa, why it has ability to cross both the CNS and also act in the peripheral tissues by inhibiting COMT. This is a minor pathway, but we have seen that this levodopa being acted on by decarboxylase, reducing the chances of this crossing the CNS. So when we give it in combination with tolcapone, it is going to inhibit, because we are going to see whenever we give levodopa and carbidopa inhibiting the action of dopa decarboxylase, hence increasing the chances of levodopa entering into the CNS by crossing the brain-blood barrier. What happens, it reverts into the pathway of COMT in the peripheral tissue. But when we add a drug like tolcapone, we are going to see this tolcapone is going also to inhibit COMT pathway, or it is going to inhibit formation of 3-O-methyl-dopa. And after inhibiting it, so it will increase the entry or the concentration of levodopa to enter into the CNS. So that is the importance of tolcapone. And this tolcapone is the best, but its use is minimal because it causes hepatotoxicity. It has high chances of causing hepatotoxicity, so it is always discouraged because of that. But it has ability to enter both the CNS and to act in the peripheral tissue, whereas entacapone only acts in the peripheral tissue. Also given in combination with levodopa, carbidopa, and tolcapone in combination. So we are going to see, and this levodopa, carbidopa, they are majorly given in people with Parkinson's in elderly, due due to increase in age above 60. These are the best drug. Levodopa, carbidopa in combination with tolcapone or MAO inhibitors is the best treatment. But the most problem with it causes what we call wearing off effect or flash, that is wearing off effect, which is always solved by giving dopamine agonist. So we are going to see dopamine agonists. They are going to be the best drugs to be given because they are long acting. So among the dopamine agonists, we said the major aim we are looking at increasing dopamine levels. So we can give dopamine directly. And this dopamine agonist, they are categorized into two, which we have ergot and non-ergot. Then among the ergot we have bromocriptine. Bromocriptine is one of them. Then we have also cabergoline. So these are ergot dopamine agonists. And this bromocriptine and cabergoline, these ones can be given, but they are short acting. So they are not the best. The best ones are non-ergot, which are long acting. Non-ergot dopamine agonists are long acting and effective in treating Parkinson's because of their long acting effect. So these ones, pramipexole, ropinirole, and retogotin, we have ropinirole, then we have retogotin. These ones are long acting, but the best ones are these two, pramipexole and ropinirole. They are the best because they are long acting, and for them they do not cause flash effect, or what we call wearing off effect, presented by levodopa and carbidopa. So they are the best drugs we can use in treatment of Parkinson's because they do not cause flash or wearing off effect produced by this. So as we are concluding, we are going to also talk about these remaining. We have seen type A, type B, type C. Now we are remaining with the drugs that increase dopamine levels in the synapse or in the synaptic cleft. We said apart from producing dopamine, apart from inhibiting metabolism, apart from giving dopamine agonist, we can also make sure that the little which is produced in the cleft can be maintained by stopping reuptake, or by also increasing them to act on the receptor, and also by increasing release. And the drugs which are used in this case, we are going to see drugs like which increased dopamine in the synapse. We have drugs like amantadine. And amantadine is an antiviral drug. When given, it acts in this way. It inhibits dopamine reuptake. Then after that, it also increases dopamine release. And also it decreases acetylcholine activity. So this is among the also drugs. It is an antiviral drug, but also used in treatment of Parkinsonism. Then the last one, this was group D. Then group E, we are going to talk about anticholinergics. Whereby this one, we are going to make sure we decrease the levels of acetylcholine. And among the anticholinergics used, we are going to see drugs like benztropine, Benztropine is an muscarinic, antimuscarinic, or anticholinergic. We're going to see drugs like procyclidine, We're going to see drugs like piperidine. Piperidine is also another drug. Then lastly, we can talk about this one, trihexyphenidyl. Trihexyphenidyl, piperidine, procyclidine, and benztropine. These are anticholinergic drugs. As we said, this Parkinson's is due to increase in acetylcholine, which is not balancing with dopamine. So we can use anticholinergics to release acetylcholine in the synapse or to block the, so these ones block the receptors of acetylcholine. They come and block the receptors of acetylcholine, and they do not allow the action or the activity of acetylcholine in the presynaptic neuron, hence also treating. And these ones, they have proved to be best used in treatment of drug-induced Parkinson's disease. So we can use them. So this is what we can discuss in this session about Parkinson's, where we have seen how it comes about. We have seen it is due to the failure of substantia nigra to release dopamine, hence leading to decrease in dopamine levels and increase in acetylcholine, which causes tremors, rigidity of muscles, then dyskinesia and hypokinesia. Then we have seen how tyrosine is formed and different drugs that inhibit different pathways, whereby you have seen levodopa and carbidopa given in a combination, whereby carbidopa cannot cross the blood-brain barrier, whereas levodopa crosses. So given in a combination so that they can increase the effectiveness of levodopa by carbidopa inhibiting dopa decarboxylase. But we have said it should not be given with vitamin B12. Then we have seen these ones which inhibit metabolism, like MAO inhibitor type B, selecglin and rasaglin, but we have said among them, the effective one is rasaglin, but they are also given in combination with this. We have also seen commit inhibitors, whereby the most effective is tolcapone, which crosses both the brain barrier and also acts in the peripheral tissue, but we have said its use is limited due to hepatotoxicity effect. Then we have seen dopamine agonist, whereby the ergots, the bromocriptine short-acting, then these ones are long-acting. We have ended up with amantadine, which inhibits reuptake, increases dopamine release, and decreases acetylcholine activity. Then anticholinergics, which are given in drug-induced Parkinson's, benztropine, procyclidine, piperidine, and trihexyphenidyl. Then we have said these ones are given in elderly. Parkinson is due to age. Thank you so much for learning with us from the beginning until the end, and may good Lord bless you.